Chapter 33, Simulation in Healthcare Education. Simulation is time-honored and has been used in health sciences education for decades. One or more typologies that is used to promote, improve, and/or validate a participant's progression from novice to expert. Simulation aligns with experiential learning theory, meaning that it is necessary to apply knowledge learned in the classroom. That is what simulation is. The designing of the clinical scenario should include participant preparation, a pre-briefing, patient information that is describing the patient's situation, the student's learning objectives, any environmental conditions like vital signs, patient's appearance, any related equipment and props, resources to increase the realism of the experience for the student roles, the expectations and limitations of each role for the participants, because simulation will roughly include 5 participants at a time, a debriefing process, and a progression outline that includes the beginning and the ending, and the evaluation criteria. This is all simulation. Various types of simulations exist. Written case studies that have been used for a year. The Second Life is a virtual learning environment. Stabilized patients that can involve live actors to play the role of the patient. This is extremely realistic, but one can't always practice anything that's invasive on any of these individuals. So any of the psychomotor skills, like maybe an enema installation, for example. Part-time trainers can represent anatomical parts of a human being, and they're utilized for skill. Think about starting IVs. And full-body mannequins can be labeled as medium or high fidelity. This is a good environment for student nurses to practice their skills, because some mannequins are able to be programmed to respond as a human would. They might have blinking eyes, a rising chest, heart sounds, or lung sounds, for example. Fidelity, in medical terms, describes the level of realism. So we have humans, right? Standardized patients, they're very realistic, but it also will involve a cost to schedule it and train. And then there's the risk when performing any procedure on a live individual. So we look for ways to create fidelity. We add various physical factors, physiological factors, cultural aspects to any type of simulation, and that will increase the amount of realism or fidelity for the learner. There are various benefits because there's a lot of evidence to support that simulation can enhance knowledge, competency, self-efficacy, and confidence. This way of learning allows learners to practice in a safe environment without harming their patients. This also allows opportunities for deliberate practice, so you can practice the skill over and over until you perfect it. Simulation also creates standardized learning experience so that all learners are exposed to a low occurrence but a high risk situation. Kirkpatrick identified 4 levels of outcomes that can be measured when thinking about training programs. Number 1, the reaction. Was the learner satisfied with the simulation experience? 2, learning. Did the learner score higher on the cognitive test after the simulation experience? Number 3, behavior. Did the learner perform better on the clinical unit after the simulation experience? And number 4, the results. Was there an improvement in patient outcomes after the simulation experience? These are all questions to help evaluate the simulation. There are various challenges with setting up a simulation lab. The cost for high fidelity mannequins can range from $45,000 a piece to $125,000 a piece because they are high fidelity mannequins. Remember, high fidelity has human-like processes, so they can blink their eyes, you can hear their heartbeat, listen to lung sounds. Okay, standardized patients, real patients need to be reimbursed for their time. Cost that is related to any audiovisual equipment or anything for moulage. So moulage is substances like adding blood or adding a bruise, adding a wound. Okay, that's moulage supplies. And the staff for the simulation lab. It takes more than one person to run a good simulation lab. The technology for it is complex and it can be difficult to operate. So having IT involved is vital. All right, Cotter has 8 steps. So for him, it is essentially a simulation is a change in the way that we are teaching. By trying to implement simulation within a current established curriculum or educational program, that faculty are trying to make a change movement. So John Cotter's 8 steps to leading change can be used as a framework to help any educator for simulation, as well as facilitators of simulation, implement the new teaching method within the current curriculum or any educational program. Think about the appropriate terms: androgyny versus pedagogy. Androgyny, these are self-directed individuals who use their past experiences. They build on those for the present situation. The application of knowledge is connected with the application and it is problem-centered. These individuals have a readiness to learn and need to know the rationale. Pedagogy is the science or the profession of teaching. One focuses on adult learners, which is NUR's androgyny, and pedagogy is just basic teaching of the nursing profession, nursing skills. Adult learners come with their own thought process. So situated cognition applies to various learning domains. Psychomotor domain focuses on the precision of performing a skill or an assessment. The cognitive domain is the application with thinking. So that means, can you perform, identify, maintain, communicate? Can you provide? Can you prioritize the tasks that need accomplished? The affective side, or the affective domain. This is where the emotion from reflective thinking happens. So by you responding to and prioritizing patient care is using your affective domain. So this model for Lassiter can be applied to simulation for noticing and assessing patient situations, patient conditions, and interpreting those assessment findings of the patient, responding by actually developing a care plan with interventions, and then reflecting the learning process during the debriefing process. So this applies to simulation. Think about noticing and assessing the patient, then interpreting the findings, developing a plan of care and interventions, and then reflecting during the debriefing process or assessment. For Jeffries, there is a triadic relationship between the teacher, student, and educational practices. and the influences on design as well as desired outcomes. There are 5 possible outcomes of simulation, and these are increased knowledge, improved skill performance, enhanced learner satisfaction, and improved and critical thinking capabilities, and increased self-confidence of all the students. A clinical scenario should be developed based on specific learning objectives for the participants. Since many simulation experts believe that the majority of learning occurs during the debriefing process, a planned theory-based debriefing strategy should guide the facilitator of the debriefing during the process with the students. A theory-based debriefing is an active discussion that follows the simulation experience. The debriefing is led by a facilitator who is prepared to apply the educational principles in guiding the discussion of the clinical content, experience, and objectives that are underlying the simulation experience. For the development process, the International Nursing Association for Clinical Simulation and Learning, or the INACSL, their board of directors in 2009 to 2011 developed the standards at the request of the membership and needs analysis. After the initial drafts, the standards were then reviewed by invited content specialists and then sent to the membership. Currently, the Standards Committee is working on updating the standards and developing guidelines. So there are various steps for the simulation process. You assign the pre-simulation or pre-scenario exercises to be completed by the students. There is a pre-briefing session immediately before the simulation. The simulation scenario with appropriate facilitation must be ensured by a trained facilitator. There is a debriefing or a guided reflection period, and then there's post-simulation exercises. Although there is growing interest in adopting clinical simulation in educational programs, there is still a gap in empirical research that identifies the validity and the reliability of the tools for evaluating the clinical simulation effectiveness. So especially when translating knowledge and skills from the exercises of the simulation to actual clinical practice, there is still a lot of research that's necessary. The educator needs to look outside of the graduate nursing education for research related to simulation and look at the outcomes of the research. Simulation has been used in other healthcare specialties for many years. Anesthesia has been using it for over 20 years. Research in other areas can easily be extrapolated to graduate healthcare education. As of now, journal editors will no longer publish articles only about the student satisfaction with high-fidelity simulation, because that's what most students think. But there does continue to be a need to determine if the learning is actually transferred once they get into the nursing practice. The Interprofessional Educational Collaborative, or IPEC as it's known, is composed of the American Association of Colleges of Nursing, the American Association of Colleges of Osteopathic Medicine, the American Association of Colleges of Pharmacy, the American Dental Education Association, the Association of American Medical Colleges, and the Association of Schools of Public Health. All of those compose the IPEC. So the IPEC was designed to improve patient safety, evidence-based practice, and translational research. More opportunities are definitely needed. New teaching strategies have evolved, and the strategies actually include the following. Number one, we have communication tools that we use like the SBAR, the Situation Background Assessment and Recommendation. It is more effective for professional and interprofessional communication. Simulation scenarios need to be able to practice skills, reflect on, assess any therapeutic communication, look at interprofessional collaboration, reflect on the actions and inactions of participants, and incorporate evidence-based practice. This must be done throughout the actual nursing curriculum and applying all of these aspects in the simulation. Informatics capabilities to improve patient care with point-of-care access to information through handheld devices and electronic health records. These are all new teaching strategies that should need to be used during simulation. So the Institute of Medicine reports that have been widely read, quoted, and studied since they were released in the early 2000s. The documents show that the extent of medical error in the United States, and it outlined methods that should be used to help prevent these medical errors, because most of the medical errors are preventable. So that means educational designs need to change so they can lead to improved patient care. In a survey in 2010, only about half of the respondents provided any personal information. Of the programs that provided the experiences, only a few stated this practice was utilized more than occasionally in the simulation. The logistics of scheduling multiple disciplines for simulation is one of the obstacles for interprofessional education. For graduate school students, interprofessional education simulations are an excellent way to learn how to function and adapt the practices of the profession to achieve the best patient outcomes. So these are some of the educational strategies that are since developed. The SBAR, this is a use of common communication tool that is between the physicians and the nurses. So simulation scenarios can be used to practice skills and techniques, do assessments, look at therapeutic communication, interprofessional collaboration, reflecting on one's actions and inactions, and it incorporates evidence-based science. Informatics is point-of-care access of information by handheld devices or computers, the electronic medical record, and the electronic health record. If interprofessional members of the healthcare team have access to all of the information about a patient, this could also assist in the delivery of healthcare for more holistic treatment and potentially decreasing harm to the patient. And this can all be accomplished through different simulation scenarios. So simulation educators need to continue to work with vendors to increase the fidelity and the usability of the different forms of simulation. Now, gaming is an emerging method of learning. Through the use of gaming, the students will use a computer or in a virtual environment. Standards of best practice will continue to be studied and tested as well as revised. Guidelines will be developed to help faculty more easily put the standards to use.